So I want to start by thanking everyone. We're doing better now than we were 2 weeks ago. Cases are down, hospitalizations are down, and the mobility, we're moving less, the mobility is down. And I know that this reflects sacrifices and many hard choices about seeing friends, about seeing loved ones, about where you work. But it is starting to work against COVID-19. But we're nowhere in the clear yet. Cases are down in our long-term care homes, but the deaths will continue to mount for a long time. It's critical to make sure that we pursue interventions to reduce mortality, such as vaccination in our long-term care homes, and in all the communities that are vulnerable in our province. And perhaps most worrisomely, the new variants of concern, the mutated SARS-CoV-2 virus, are clearly spreading in the community and will likely be the dominant version of the virus in March. We're just learning more and starting to learn a lot more about how the UK variant called B117 spreads. That's the one that we have very clear evidence that's here now, and how it makes people sick. We'll talk about all this today, but I want to make sure that we're all on the same page about three things as we begin today. First is that we are making progress. Cases are down overall, but the uptick in cases today is concerning, and the new variants, like the variant from the United Kingdom, give us less room to relax and less room for error. The current public health measures should work against the new variant, but the countries that are fighting the new variant successfully are the same ones that have kept the public health measures in place. Second, this vigilance does not mean that schools have to stay closed. International evidence and some of the modeling that we'll present today suggest that if we are careful and if we watch the data carefully, it should be possible to control the spread of the disease with schools open. It will be a challenging decision for the province's leaders, and it may require different approaches in different regions. It's not easy, but it is possible. And third, workplaces are critical. Despite the current public health measures, the fact is that many Ontarians can't stay at home. They're working on a factory line in southwestern Ontario, they're at a food plant in Simcoe, they're at a warehouse near Pearson Airport, or a grocery store here in Toronto. They have to work near each other and they have to get to and from work. These essential workplaces are highly associated with the risk of exposure to COVID. And just like a forest fire, if we don't pay attention to the hotspots, the whole forest will keep on erupting into flames. And just as there's a healthcare front line, there's an economic front line, and it's critical to limit spread in both of these front lines, for these workers and for their families. And before I start with the overview, I want to make sure that people recognize that today is Bell's Let's Talk Day, and a very important reminder that mental health impacts are a major part of the pandemic. We don't have data to present on this today, but a Leger poll that finished on January the 17th reported that a quarter of Ontarians say their mental health is bad or very bad. It's affecting all ages, from children to the elderly in isolation and everyone in between. We'll be launching a specific group to work on this, so you hear more going forward. But in the meantime, with a little bit of good news, the cases being down, it is helpful to remember that while we're going through a very dark period now, this will end. Now, let me start, as I always do, with the big picture for Ontario. And my apologies, when we do go onto the slides, we'll lose the sign language translation for a little while, but it will be back. My apologies about that. If we could go to the slides, please. Great. So as we always do, we'll start with some key findings. As I noted earlier, cases and positivity are down across public health units around the province, but testing volumes until today were also slightly down. It's going to be important that we maintain high testing volumes to keep control of the pandemic. This includes the current type of testing where people present at assessment centres or where we do testing at particularly high-risk settings. But it also involves surveillance testing, testing where we both think the disease will be and where we don't think it will be, so that we have true eyes on how the disease is spreading and, given the new variants, how it's evolving across the province. Cases are declining across long-term care homes, but the deaths continue to rise. When we put together these slides a day or two ago, it was 215 deaths in the last 7 days. We're still on track to surpass the number of deaths in long-term care that happened in the first wave. And so interventions to reduce deaths in long-term care will be critical. Hospitalizations are declining, which is good news, but the strained ICU capacity continues. And I think it's important to note that COVID-19 has an outsized impact on our health system. And this means that the access to care deficit is continuing to grow and already has short and will have long-term negative impacts on health. There has been a reduction in mobility. This is good. But essential work that I just talked about a few seconds ago is still strongly associated with the risk of exposure to SARS-CoV-2. And safe workplaces will be important to control COVID-19. The new variant of concern, B.1.1.7, is spreading in Ontario, and it is a significant threat to control the pandemic. However, as I noted, the modeling we'll present today and some of the international examples suggest that if we are able to keep our reproduction number down far enough, as the B.1.1.7 variant becomes the dominant variant, we may be able to do things like keep schools open and maintain the reduction in cases. I'll turn to the slide that we always start with, and this is the total new cases per 100,000 residents per week across the public health units. And you'll see in virtually all, not all, but virtually all of the public health units, cases have come down substantially. There is obviously today, data not included here, an uptick in cases in a number of areas. This is concerning, but overall the trend is towards lower case numbers. And you can see a similar pattern here with positivity. Down in almost all of the jurisdictions here, in almost all the public health units across the province. Today, actually, you'd see probably a further decline in positivity. Part of that's because we've seen an increase in the number of tests today, which is not sort of a surprising situation to see more tests, more cases, and declining positivity. But still, it's important to keep an eye on the number of cases. And the last two slides looked at the situation across public health units. Here, we're looking at the situation across age groups. And as you can see in the top panel, we're looking at the cases per 100,000 population. In the middle panel, we're looking at tests per 100,000 population. And in the lower panel, we're looking at percent positivity, the percent of cases, or percent of tests, that come back positive. If you look at the dark blue line, that's the oldest age group, people over 80, and that works its way down to the bright red line, which is the people under 10. And as you can see in across the province and across the age groups, the total number of cases per 100,000 population, all age groups, has come down. There's a little bit of an uptick in some of these groups recently. Looking at tests, you can see that stabilization of tests, and if we had today's data that was reported this morning, you'd see that it's actually slightly up in terms of the number of tests. And the percent positivity, although also with an uptick, is down overall, and today's data would make that trend downwards a little more pronounced or a little more clear. So we are seeing a reduction in the number of cases, and we are seeing this across all of the age groups and virtually all of the regions and public health units. But obviously the impact continues here with deaths in homes. Although cases have dropped, and our last peak of cases was January 14th. We have today, I can actually update the figures that are presented here. We have 207 deaths in the last 7 days. That's 206 residents and 1 staff member. We have 693 resident deaths since January 1st. And it will take a while for that drop in cases to translate into a drop in deaths, because people who are dying today were infected weeks ago. And it's just unfortunately, although vaccination is progressing, it will be a while until you actually see that surge in cases that stopped on January 14th actually filtering through. Important to note as well, we have a number of outbreaks still. This number is actually coming down a little bit, which is good. We only have 229 long-term care homes in outbreak as opposed to 256 when we put together this slide a day or two ago. And unfortunately, only 67 of those outbreaks in this case, though, have only 1 case. That's down from about 80. At the last briefing, we showed a series of maps that showed the progression of outbreaks across long-term care homes across the province to illustrate the dramatic change from the summer to the fall, and then the quite dramatic change as well from the fall now into the beginning of January. This is the map from January 7th, which would have been the last map we presented in that series at the last briefing. If you go from here and you look now at the pattern for January 24th, you can see that there are fewer circles today, and actually with the updated information from today, there'd still be fewer circles, but still largely disseminated across the province and still substantial risk of outbreak across a number of our communities. It's important to keep in mind that the predictor of whether or not we get infections in a home is the level of infection in a community. So there is still risk of continuing outbreaks in long-term care homes, and those will unfortunately lead to continuing risk of death in long-term care homes. Moving from long-term care homes to mobility, this is a graph that shows smooth mobility. What it's really showing is using some techniques to try to understand when people are moving around and how much they're moving around. Ontario is the darkest blue line, and in comparison to some of the other, actually in comparison to all the other provinces that are reported here, you can see that there has been an actual reduction in mobility since the stay-at-home order. You see obviously a reduction over the holiday period when people are staying at home. It started to rise again, and then following the stay-at-home order in the last technical briefing, you can see it coming back down again, which is positive and likely the cause of the reduced number of cases. But drilling into Ontario here and looking at some of our highest risk or highest rate public health units across the province, you can see that there is changes in mobility, but in some of our hardest hit areas, they are less than you might want to see. The left-hand panel talks about the percent of time that people are at workplaces, and the right-hand panel talks about the percent of time that people are at home. And if you really sort of look at this, the mobility index here that we're calculating, in workplaces there is a drop during the Christmas holidays. That's to be expected, that during the Christmas holidays people will be away from workplaces. It starts to come back up, but has not reached the same level prior to the Christmas holidays. If you look at residential work as well, you can see that there was a drop again. Sorry, there was an increase obviously during the holidays as people stayed more at home. This, of course, has started to come down following the holidays, but it has not come down to the level prior to the holidays. So there has been a reduction in mobility. This is something that obviously can change as we go along, and it's really important to note that this can change quite quickly. And as mobility changes, contacts change, and with the increasing prevalence, the increasing risk of actually contracting one of the new variants, you're going to see that infections can jump up and rise quite quickly again. Before we leave mobility, though, I want to come to the question of essential work. So this chart divides Toronto into communities based on how many people in the community, or the proportion of people in the community, who are engaged in non-healthcare essential work. These are the people who are not able to work from home. And the red line shows is the rate of cases in those communities that have the highest percentage of people working in non-healthcare essential work. You can see for all of these curves, red being the highest and the light blue, or the sort of blue being the lowest, for all of these groups, case rates have dropped, which is important, or case numbers have dropped. But it's important to note as well that the rate of cases is still higher in the community where most people, the highest number of people are engaged in essential work, and it is higher today still than it was at any point in any of the other sort of groups that we're looking at here. And so this is a place that, or this is a graph that I think really shows the importance of ensuring safe workplaces. This obviously involves prevention at the workplace, but it also involves ensuring that sick people do not have to go to work. So really this is the place where we can see continuing hotspots and that can still flare up at any time. Moving on here, we're showing the epidemic curves here for a number of countries that we see as pure sort of systems: France, Denmark, the Netherlands, the United Kingdom, Germany, and Ontario there in sort of the orangey pinkish line. What you can see is that there's a number of countries that have actually seen a decline. In all of those places where we've seen a decline, even as the prevalence of the variant of concern increases, are the countries that have maintained the stringency of the public health measures. And obviously the exception there is France, that recently reduced the stringency of its public health measures. And you can see in that red line, it's now starting to creep back up. And so a big challenge, obviously, to maintain public health measures, but it's really key to controlling the spread of the new variant. You can see here, this is the case curve that we've got for Ontario that we show every time. Whereas prior to the decrease that we've seen now, we were projecting an increase. Thankfully, the reduction in cases means that we're now projecting a decrease. You can see that the total number of cases comes down. If we're somewhere between 1% and 3%, which is likely where our case reductions are right now on a daily basis, we will get down to close to close to between 2,000 and 1,000 cases a day by the end of February. The line there, though, that goes down and then curves up that's labeled VOC shows what might happen if we have increasing prevalence of the variant of concern and we're unable to break that transmission, because it will continue the decline as the current variant decreases. But as the more transmissible variant takes hold, as that UK variant takes hold, its increased transmissibility will actually lead to an increase in the total number of cases as we move along. So the variant of concern remains a very big challenge to control the pandemic. Here you can see the ICU occupancy. The red line at 150 is thankfully the lower threshold at which we start to see our health system being compromised. You can see that under different scenarios, we don't quite get to that red line, although at 3% decrease, if that's where we are, we will get to that line in terms of ICU occupancy, or close enough. That's very reassuring. But important to note here that the VOC line, as it starts to take hold, it doesn't start to turn upwards again, because there's obviously a delay between cases and ICU admissions as patients' conditions worsen. But it does start to turn up, and it does start to also turn up the impact on our intensive care units. And just to reinforce the point that intensive care capacity remains strained in most regions, you can see here the red and the orange lines are those ICUs across the province. This is all the intensive care units across the province. You can see those in red and orange are those where there are none or only 1 or 2 beds free. And you can see in a number of those intensive care units that almost half, or in some cases more than half, of the beds are occupied with COVID-19 patients. And so you can see in a number of our regions there is still extremely strained capacity on our intensive care system. And it's important to note that a number of these hospitals that are showing this really kind of to the limit capacity are also regional referral centers. So it does impact across the province. This slide gives you a sense of the relative impact of COVID-19 on our healthcare system compared to two bad flu seasons, the 2018 flu season and the 2009 flu season. I want to call attention to a few things on this graph. At no point during the previous bad flu seasons did the number of beds occupied by patients come anywhere close to the peaks that we've seen with COVID-19. The second thing to note is that for only a very brief period of time was the max number above the total number occupied by COVID. And so that space between the red line and the blue line, whether you look either at the dark blue line for 2018 or the light blue line for 2009, at no point, that's a huge gap, which represents a huge strain on the system. Instead of thinking about this in terms of the maximum number of beds, if you want to think about this as bed days, right now, we haven't even put in a full year of caring for patients with COVID-19, but you can see that red line counts for 585,000 bed days. In contrast, the 2018 flu season accounted for 139,000 bed days, and the 2009 flu season for only 92,000 bed days. Work done in Ontario shows the mortality from COVID-19 is about 3.5 times that of flu. A much higher demand on ICU care and a much longer length of stay. It's important to note that it also is a lot more time per patient, both because of the infection control procedures that are necessary around COVID-19 and the severity of the disease. And I think important to note is that it's one thing to tolerate a surge in a season that then resolves within a month. Right now, the people working in our intensive care units and people working in our hospitals have been working at a level that is beyond any of those surges for a prolonged period of time. And this reflects a huge strain on our health human resources. And you see reports regularly about people starting to suffer from burnout, exhaustion, and leaving the professions. Of course, this impact on our healthcare system does contribute to a decline in access to care, and the access to care deficit continues. This is important because it's not just access to surgery, it's access to all the other aspects of care along the care pathway, right back to prevention and screening. As these things are compromised, you will see a long-term care deficit that starts to pay, unfortunately, very, very big consequences in the future in terms of problems with cancer, heart disease, chronic disease, mental health, and other conditions. I want to spend a little bit of time just talking about what we do know about the new variant, B.1.1.7. This is the variant that was first identified in the United Kingdom. It is spreading in Ontario. We know that the transmissibility is likely at least 30% higher, if not more. In the UK, it looked like it was about 56% higher. The secondary attack rate, and that's the likelihood that an infected person infects their contacts, is about a third higher. And the reproduction number, that's the number that we've talked about a lot, which is the number of sort of people that get spread, you spread it to, is much higher as well. What this means is that if the reproduction number is higher for this variant, you need to keep the reproduction number for the current variant much lower. The Danish estimate right now is that in order to maintain their current downward trajectory, they have to maintain a reproduction number of 0.7. So not just below 1, but 0.7 to really compensate for that increased transmissibility of the new variant. There's also concerning evidence or concerns right now in the United Kingdom that there, and I'll use the exact language from the report, a realistic possibility that infection with variant of concern B.1.1.7 is associated with an increased risk of death compared to infection with non-VOC viruses. So essentially saying that there's significant concerns that the new variant is more lethal. There's some question, as I speak to some intensive care physicians, that this is the reported excess mortality is due to the incredible crowding that they've seen in their intensive care units and the inability to provide sufficient care to people. But even it looks now in the reports after some adjustment for that increased lethal nature of it is there. Vaccines are likely still effective against B.1.1.7. And we note that there are other variants of concern, the one that's been identified in South Africa and the one that's been identified in Brazil, that both also have this increased transmissibility and increased risk of reinfection. And I think it's important to note that these are not the only variants that will emerge. As the disease continues to spread and becomes more and more common, the new variants will emerge, and some will be able to outcompete the current variants. Right now, just to get a sense, the Danes, who are trying very hard to kind of keep control of this, are probably about 2 weeks ahead of us in terms of the prevalence of the virus in their communities. However, I think the really important thing to note in all of this is that the current public health measures that we employ against this variant are the same public health measures that we would employ against the new variant of masking, of social distancing, of making sure that people are not getting into crowded, confined, and closed spaces, of hand hygiene, of the full range that we keep on emphasizing, same public health measures that work against the new variant. And if we are able to maintain adherence and the downward trajectory in our cases, then opening of schools is unlikely to create a big amplification of the current case volume. Now, this is something that I really want to be clear that this requires a downward trend in cases. It requires vigilance. It requires expanded testing. It requires careful monitoring of what's going on. It requires surveillance of the disease in the community and in schools. But as you can see, the blue line reflects the total number of cases if schools were open, and the red line or the orange line reflects the total number of cases with schools closed. And you can see it's a relatively small difference if we maintain that downward trajectory in cases. So it really emphasizes the importance of continued public health measures. We'll just close here to talk a little bit about the total number of COVID-19 vaccine doses that have been administered. This is data from a day or two ago at 295,000, almost 296,000 doses. This morning, the number would have been 317,000. This is not reflecting the total number of people who've received both doses. It's just the total number of doses administered here. And so you can see an increasing number of people receiving at least one dose of the vaccine. Just coming back to the key findings, cases and positivity are down across public health units. It's going to be important to make sure that we have sustained high testing volumes, some of which is for identifying or testing people who might be sick, but also to make sure that we have eyes on the pandemic, and that's actually the function of surveillance of the disease. Cases are declining across long-term care homes, which means eventually deaths will stop increasing as well. but we're still seeing a strong accumulation of deaths, and we're likely to surpass the total deaths from the first wave. And so interventions to reduce deaths in long-term care, and actually in any of the vulnerable settings where we have people who either have lots of comorbidities or who are older and are living in a congregate way are there together. Hospitalizations are declining, but ICU capacity is still strained. There has been some reduction in mobility, which is probably explaining the reduction in cases, which is a positive thing, but it's important to make sure that we not only maintain the reductions in mobility, that we also make sure that workplaces are very safe. And the new variant of concern is spreading in Ontario and is a significant threat. However, the modeling and some of the international examples suggest that we can use the same public health interventions and we may actually be able to still return to school. And with that, I'll just close on the contributors to today's briefing and turn it back over to Dr. Williams and allow the sign language translation to come back.
Okay. Well, thank you, Dr. Brown. And we'll be taking questions in a moment, and I'll have some comments to make. First, let's just look at the numbers and data today, and then I'll have some comments to make in accordance with Dr. Brown's presentation. Since we last spoke on Monday, Ontario's reported an additional 5,503 cases of COVID-19, and another 168 people, unfortunately, have lost their lives in this time. And we've seen some cases under the age of 60 as well. And that's been very concerning, and of course, condolences to the families in that regards of all of them. The 7-day average rests at 2,128, and that's down from 2,751. So that's a significant drop. And today we recorded 2,093 cases, as Dr. Brown alluded to, an uptick from our cases where we were under 2,000 for about 3 or 4 days in a row. But our volume of testing is up as well. And we've seen that was dipped over the weekend, as it usually does. Today, yesterday we had 55,191 tests done. Today, 64,664 cases done. But our positivity rate, as Dr. Brown's alluded to, had dropped down to 3.3%. And we haven't seen a rate under 4% for a period of time since the early parts of December. The hospitalizations are declining slowly. And this is a late adjustment. And that's what Dr. Brown alluded to. We had 1,338 in the hospital, and our ICU number down 358, where it was up in the up 310, 314 level a week ago. So encouraging, but it's a slow plateauing and coming down, but it takes a while to have an impact if the cases keep coming down. We have been looking at the variants all along, and there's two things we're paralleling here. One is that we have been looking at variants all along. We have our basically our genomics group that's looking at samples throughout the fall with well over 8,000 ones run through looking for any variants, and they hadn't found any up until into December. And then we started notifying you of cases in certain locations that were identified, especially with travel history. And then I'd be happy to say that our lab in Ontario has developed a special PCR test, the only one in Canada and probably unique in North America, that quickly identifies any one of the 3 variants that have a certain mutation of 501 on it very quickly. So that means we can tell that soon any positive test, is it have one of those variants, yes or no? We can't say specifically which one until we do the whole gene sequencing, which does take a period of time, almost up to a week and a half sometimes to get that completed. So we've been doing a number of tests and screening on that one, and we have identified so far 51 cases, but there are more coming with more testing being done. And we will see that because we now have the technology, and we are sharing that technology with the National Medical Laboratory in Winnipeg, and so that it might be utilized on a pan-Canadian basis, perhaps. We've seen the most of our cases that we have seen of the variant, unfortunately, have been in Simcoe, Muskoka, related to the outbreak at the long-term care home, combined with a retirement home in a place called Roberta House. And so we are continuing to test the number of samples there and to ascertain that. So far, we are identifying a number that are suspected, and we're continuing to update that list. And we're also doing a point prevalence study looking at a certain day in January and testing all the samples there. But it's our hope that with this new technology, we'll be testing all positives to see. Give us a heads up of any variants that are moving in around the province. As Dr. Brown's alluded to, since the December and the end of December, it has been around, and with its transmissibility, there's a high chance that it's moving quite aggressively in some areas and leading to community-wide spread. And Dr. Yaffe and I have been alluding to that over the last number of weeks. The question is how wide and where are the impacts of that? Now, the other thing is that we've tried to isolate. We have not seen yet, unlike Alberta and BC, any of the South African. We're looking for it. And we're looking to see if we have any of the Brazilian also. So that's another reason why we're doing this enhanced testing, enhanced monitoring, and checking for it. And we will be updating you if and when we do find it. But our goal is, of course, with strict testing, we can keep that under control and keep the percents down as we have so far. And it may have been fortuitous that our lockdown on Boxing Day, as well as the stay at home, has kept it down at the same time when the UK variant in particular, the one we've located and isolated, was coming into our communities in that period, and unfortunately has resulted in a large outbreak in one of our long-term care homes and affiliated areas. On the vaccine side, we've administered over 280,000 doses of the vaccine thus far. We are in the midst of the pause a bit with the Pfizer delay, and we're hoping to pick back up on that around the 15th of February. We're getting some coming in. We still have the Moderna coming in, and so we're trying to keep our priority groups going as rapidly as possible, making sure we're seeking to immunize that means 2 doses to our long-term care residents in our hotspots, and we nearly have that totally completed. We hope to have all of them done by the 5th of February. A task to do with our supply and moving it around to try and deal with that as quickly as we can. And then when we get our vaccine coming back again, to get to our priority list and catch up on those as soon as we can, still keeping enough back so that we'd like anyone who has had a first dose, including our healthcare workers, will get their second dose within the time frames we alluded to in a period no longer than 42 days. And so we want to achieve that and obtain that goal. Some have asked about the safety of the vaccine. We continue to monitor very carefully for any what we call adverse events following the vaccination. In that, we've had so far 83 adverse events out of the 280,000 doses administered. And we have 40 of those were received during the week of January 17th through the 23rd. 82 of the reports were non-serious. One was, and they had to get medication. None have been hospitalized at this time in Ontario, but any ones of any concern are investigated and assessed to whether it is related to that. Most events are allergic skin reactions in there. So where are we at? And I think there's a reason to take a pause. Dr. Brown has given us both 2 things. One, it shows improvement. And I would like to thank the citizens of Ontario that where we had not seen a lot of decreased mobility during the holiday season, the post-holiday people have stepped up to the task. The drop has been apparent. We've seen the number coming down. Our effective has come down. And we've seen all the rates in the regions come down. So that's good reason for optimism. At the same time, Dr. Brown is saying it's precarious. And we have to be very careful, especially when we're dealing with the issue of the variants of concern. And in particular, the B117 or the UK so-called variant that was identified in the United Kingdom. So we continue to use that caution, and that means then the steps that we had taken, we're going to have to be very careful on, because the transmission, as Dr. Brown said, is much more, is higher, about 30% higher. So that means a smaller exposure period without protection leads to a much higher chance of infection. So what used to be considered an intermediate or moderate risk of exposure is now a high risk of exposure. And so what you did before, you're going to have to do it again and do it really well, especially in and around others, because a lot of the people who are transmitting seem to be in the pre-symptomatic or asymptomatic phase and are not aware that they're doing that at that time. So we are asking people to remain vigilant. The vaccine's on the way. The vaccine has shown still to be effective against the 3 variants we're talking about today. We were hoping to get that as quickly as we can. We want to get the vaccine orders back online. I know General Hillier is hoping to get the priority groups up and running and happening as soon as possible, as we can do with our most at-risk ones. So in this time, it's Bell Let's Talk Day. And while we talk about the people and we want to talk and connect, and you shouldn't do it in isolation alone. We're seeing that impact more and more as the outbreak, as the pandemic goes on. And people who really had no mental health problems are having stress and anxiety issues. And I can't overstress how important it is to reach out and talk, reach out and text. Sometimes just a text message means a lot, but some people hearing the voice that they're in means a big difference. And you may not need to think you have that, but sometimes it helps to have that, and knowing that in your seemingly isolation, you can connect and talk to. Think of those people who might be in isolation. Maybe you haven't talked to them for a while. Maybe you should get on the phone and talk to them, especially some don't have social media. The old landline, and some of the people, especially over a certain age, may still like to have the phone call. But utilize all the forms we have there, as is the day, to connect, reconnect, and to stay connected, because you want to monitor, support each other, and help each other. And so nothing could be better for that than today's celebration, or I would say more awareness through the Bell Talk Day. It's necessary, it's vital. Do connect, do talk, and do support one another. So it's been a difficult year. We continue to work at it. We've heard that we're making progress. We're fighting this new level. One, the surge at Christmas and New Year's and holiday seasons, and now we have the variant. The same methods that worked against those will work against the variant. We're upping our ante on testing, on monitoring, on people with travel history. We're trying to work at that aggressively and assertively, and we want to make sure we keep on top of it. We have our new technology, and so that when we know, you will know. And we're trying to keep you informed. But as Dr. Brown said, it's pervasive all through the province. So you may be sitting within a very quiet area at the moment, but all you need is certain people and certain events and certain ways without the proper checks and balances, and it can really take off very quickly.